The painkiller addiction crisis in Oklahoma. Many watching this video already believe that they know all about the painkiller addiction crisis. But what we have seen thus far is only the tip of the iceberg. We've seen a lot, but we hadn't seen nothing yet. Much is still below the surface, and I want to give us a little insight as to what lay underneath the surface that's about to hit us. First, let's start with understanding what opioids are. Opioids are a class of drugs that are known as analgesics. That means they are pain relievers. They numb pain. Natural opiates are opium, which are grown from poppies. Older synthetics include morphine, codeine, both of which are prescription medications, but also heroin, which is illegal. The new prescription drugs that are most often seen on the streets, or even obtained by prescription, are hydrocodone, which include Vicodin, Lortab, oxycodone, which is Percocet, Tylox, OxyContin, and hydromorphone, which is Palladone and Dilaudid, oxymorphone, which is Opana, and methadone. Now, the way that opioids work is that they numb the pain receptors to the brain. Now, this numbing causes a rebound effect when you come off the pain relievers or you withdraw from them. So this creates a hypersensitivity. Now, chronic abusers of painkiller drugs, narcotics, create within themselves a chronic hypersensitivity to pain. Now, this chronic hypersensitivity, it just kind of amplifies their perception of pain, both physically and emotional. Pain that you or I might find something that we can live with becomes excruciating and unbearable for a person who has hypersensitivity to pain because of their chronic abuse of painkillers. So even people that have been treated for legitimately for pain management can develop this hypersensitivity to pain. Now, what's interesting is that this is not just physical pain, but emotional pain. For years in the substance abuse treatment field, before the wave of painkiller addiction occurred, the predominant opioid addiction that we saw was heroin addiction, and they were some of the most difficult addicts to get off their drug of choice. They were often more emotional, they were often more whiny, etc., and this is true for most painkiller addicts. The traditional treatment modalities and approaches tend to have very poor outcomes. SAMHSA data indicates that their positive outcomes rate is somewhere between 6 and 10%. So that's not a very good success rate. However, there is a best practice identified by the federal agency SAMHSA, a medication-assisted treatment that we'll speak on more later, that has outcomes from 70 to 75% success. Now, heroin, as we mentioned earlier, heroin addiction in Oklahoma is only responsible for about 5% of the substance abuse treatment admissions. It's only about 1.3% of the adult population. What's interesting, however, is that heroin addiction comprises about 26% of the overall probationers and parolees Oklahoma prisons. And so what we see is probably a ratio of 5 times the rate of criminal activity or incarceration, at least, among these addicts than other addicts. Now, another thing that we want to note about heroin in the state of Oklahoma is that heroin is cheaper, it's purer, and it's more prevalent than it's been in many, many years. And so that is going to present a problem that we're going to discuss here in just a minute. But it used to be said that you couldn't get addicted to heroin by smoking it or snorting it. That's not true any longer. There's some very powerful heroin that's out there right now. So, getting back to the painkiller addiction topic, it's official. Oklahoma leads the nation in prescription painkiller addiction. In March of 2008, SAMHSA identified Oklahoma as the leader. stating that about 6.7% of the population over 12 years old uses prescription painkillers for non-medical purposes. The DEA states that the most popular pharmaceutical substance abused or diverted in Oklahoma are the hydrocodone products. So just how big is this addiction? Well, the Oklahoma Bureau of Narcotics and Dangerous Drugs states that there are 87,000 painkiller addicts in Oklahoma. Looking at the Bureau of Census data for 2006, prorating it over per capita basis per county, that would be about 13,000 opioid addicts in Tulsa County alone, and 17,000 in Oklahoma City. But if you look at the SAMHSA data in 2008, that's 6.7% of Oklahomans. That indicates over 200,000 in the state, which would be in Oklahoma City or Oklahoma County over 60,000 people. That's a huge number of people, a huge mass of people that are addicted to prescription painkiller drugs. Among prescription addiction, painkiller addicts represent about 2/3 of that population. So who are the addicts? Well, it used to be that when we thought of opioid addicts, we would think about heroin addicts that were like stringy long hair, back alley, dirty, etc. But that stereotype is no longer accurate. I don't know if it ever was accurate, but it's especially not accurate now. The typical opioid addict cuts across all socioeconomic strata. We have seen famous actors, Rush Limbaugh, a conservative talk show host, radio talk show host, the wife of the Oklahoma district attorney back in 2002, who was a physician. These are people that don't fit the normal ideas of when we think about opioid addicts. It includes the elderly, the people that have chronic pain problems, professionally educated people, the young and internet savvy. Now that is going to play an important role in our discussion in just a few minutes. There is a huge growth of painkiller addiction and opioid addiction among young people. It's gotten younger and younger over the years. Now, here's the rest of the story, as Paul Harvey, a famous Tulsan, used to say. As the mass of people that are becoming addicted is growing by leaps and bounds, our supply of the drugs is going to shrink dramatically because of a DEA crackdown. Now let's look at what the history of this shrinking supply of painkiller drugs. In October 2003, President Bush had ordered all government agencies to come together to address this problem. So the FDA and the DEA partnered to shrink the supply of these available painkiller drugs that are on the streets, are being diverted. And so as a part of that DEA crackdown on March 1st, 2004, they announced that they were going to implement a prescription monitoring system to track physicians who prescribe narcotics and find those that overprescribe. And they reclassified hydrocodone so that you're unable to fill it without a new prescription, and other drugs like that. And they started prosecuting doctors for large amounts of prescriptions. In 2007, they noticed something, that there was just a huge onset of online pharmacies. Now, you probably remember getting all of that spam in your inbox. I mean, 10 and 20 emails a day sometimes, depending on what your web surfing traffic looked like. But some of that has kind of, you might notice, has died down a little bit. Well, the reason for that is in 2008, the Ryan Haight Online Pharmacy Act was passed, giving the DEA the authority it needed to shut down a lot of these illicit online pharmacies. And so what happened is that a main source for drug that fueled the addiction growth was shut down. You know, what you have to understand is that when you got those that spam email, there was usually a link, a hyperlink in there, and you could click on that hyperlink and go to a website and basically pick what you wanted and how much you wanted. And so what you would do is you'd click on a drop box and select your drug, if it was Oxycontin or Lortab or whatever. Then another drop down box would have a list of questions, and you'd simply say yes, 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 yes to all of those questions. And there was a doctor on the other end of the internet there who was willing to put their license on the line and say that was a medical examination and write you a prescription. So what happened was people had cheap and easy access to these drugs. And so you can imagine why all of a sudden this painkiller addiction just mushroomed. And so if your tolerance grew too much and you weren't able to satisfy your addiction based on the prescriptions that you had, all you had to do is go to the next email in your inbox and click on another hyperlink and order some more. And it was virtually unrestricted. What they could even do was begin to order those and sell them on the streets to kids to help finance their addiction. So there was cheap and easy access to these drugs that allowed even people that started out with legitimate pain management problems to foster this addiction as it began to take control of them. And so the result, 200,000 people in the state of Oklahoma suddenly becoming sick and desperate. Why? Because their supplies of these drugs were shut down. And so what does that look like? Well, there was an Oklahoma City attorney, July 27th of 2006, who made front page news. He had jumped out of his hospital room in a hospital gown, and somebody caught his picture plummeting toward the ground. What was the story behind that picture? He was so desperate for Oxycontin that he, an attorney, a licensed attorney, showed up at a pharmacy and held them up at gunpoint. And when he got his Oxycontin, he began to eat it right there on the spot, downing those Oxycontin. And when the police arrived and took him to jail, there in jail, he tried to commit suicide. So they took him to the hospital, and there he was jumping out of the hospital window, and that picture made front page news at the Daily Oklahoman. Why is this a big problem? Well, understandably, not just masses alone, but the traditional substance abuse treatment is only 8 to 10% effective, according to SAMHSA studies. So SAMHSA has been studying this for a number of years, and they have discovered an evidence-based best practice called medication-assisted treatment, which is described in their Treatment Improvement Protocol 43. This medication-assisted treatment has 75% positive outcomes, a great success rate. It's 9 times better than traditional treatment. And the real beauty of it is that you can skip inpatient detox. Now, I recently heard from one of the ODMH-SAS directors that there was an 1,000 to 1,300 waiting list on any given day in Oklahoma for an inpatient detox bed. So that means that you're probably waiting for 3 weeks to a month to get that person into treatment. So let's say that you are a case manager, some social service agency. You've got a client that you've been wanting to get into treatment. They finally have seen the light. They want to change. They decide today's the day, I'm ready to do something. You pick up the phone, they tell you a month down the road we're going to put you on the waiting list. Let me ask you something. Do you think that addict is going to be ready for treatment in 1 month? Chances are not likely. Chances are you won't even be able to find them. They're going to have scored again. They're going to be off and running and hopefully still alive. The other beautiful thing about skipping inpatient detox, a lot of times with medication-assisted treatment, since you're using medication on an outpatient basis to manage withdrawal symptoms, they don't have to go inpatient, therefore they don't have to leave their job. They can continue working. They can continue, if they're working, that means they're continuing to get a paycheck. If they're continuing to get a paycheck, they're continuing to keep their home in place. They're paying their rent. If they're keeping their home in place, they keep their family together. All of these are the stabilizing support structures that are very difficult to put back together if they fall apart when the person finally decides to get treatment and get into recovery. So let's look at how this progression of painkiller addiction troughs. Yellow line in this graphic depiction shows people that are able to manage their addiction through cheap and easy access to drugs online. Now all of a sudden that supply is shut off. And so what happens now? So what happens is they get very, very sick. They don't have access to the drugs at the same rate to sustain their addiction at the level that it is. They don't have the money. They get very sick. They start calling in sick. They lose their job. They have to do something, so they're exploring other ways to get drugs that involve criminal activity. They encounter the criminal justice system. They lose their home because they can't pay their rent. They lose their home. What happens to the family? Well, those kids have got to go somewhere. Child welfare gets involved. There's the breakup of the family. Then furthermore, these people eventually lose their health. Now, I used to run teams that intervened with that outreached homeless populations. And let me tell you something, that when we encounter these people on the streets, their lives are in such turmoil, and their addictions and their health problems and all these problems are so great that the intervention requires a matrix of very intensive, very expensive services. And let me tell you, we rarely get them back to the same level of functioning that they were before. So we have very poor outcomes. Now, in contrast to that, the much less expensive path of the SAMHSA best practice is that blue dashed line of medication-assisted treatment, where we take them right from active addiction into medication-assisted treatment. They continue working on their job. They continue paying their rent. They keep their home together, their family together, and none of this happens. It doesn't have to happen. What will happen if we don't find a way to get these people into medication-assisted treatment is we will literally clog our healthcare system, our criminal justice system, our social services systems with this mass of people about to go over the cliff. But we can't avert that through medication-assisted treatment. So what happens next? Well, drug supplies will drop, prices will go sky high, people will get sick and desperate. They'll look for alternatives. They'll try to make money, different criminal activities to make money to buy drugs. They will eventually find their way to the cheaper, easier to find than ever, more prevalent, pure heroin, which leads to needles and further into crime. Remember, the crime rate for heroin addiction is 5 times greater than other drugs. So we've got increased criminal activities, increased ER visits and hospitalizations, and increased prenatal withdrawals. It's very, very dangerous for babies still in the womb. But medication-assisted treatment, is, especially with methadone. Methadone is the only drug, it's the most tested drug for 35 years, and it's the only drug that's used for pregnant mothers who are addicted to opioids. And many, many full-weight babies, healthy babies, are birthed that way. So what we want to look at are intervention paths that help us to get back to to not go down that trough of the progression of opioid addiction. The key here is that earlier is better. If we can stop it immediately before they start that decline, that's better. We keep the support system in place. Early detection and intervention avoids the disease progression and all of those consequences that we mentioned. And the best treatment is medication-assisted treatment, identified by SAMHSA as the evidence-based best practice. And with medication-assisted treatment, we can keep people in outpatient. They don't have to go inpatient. They can maintain their job, maintain their home, and maintain their families. Now, in the state of Oklahoma, there are 14 opioid treatment programs, but not all opioid treatment programs are the same. There are safety concerns. We want to make sure that there is not multiple site dosing. We want to be checking the DEA's prescription medication system. We want to send out sole provider letters by faxes to check and see that they're not going to multiple methadone or other providers. We want to make sure that they're not supplementing their dosing. You know, these people are very adept at doctor shopping, so they will go to different places to get their drugs and even to get methadone or other drugs that are used in treatment. So we want to make sure that they're not supplementing their dosing, and the way to do that is through daily monitoring. If it's a clinic that gives them carry homes of methadone or Suboxone or buprenorphine, you know, there are in some situations you can go get a script for buprenorphine or Suboxone for 30 days, and there's no one checking up on you. They need to have daily monitoring, at least for an initial period, and where we are looking you in the eye every morning as you get your dose. We're seeing if your eyes are clear. We're hearing if your speech is clear. We're watching your gait to see if it's steady. And if we don't like what we see, that they're frequent and random, as well as for cause reasons for comprehensive UAs. And in our clinics, we give a 12-panel UA that detects not only the drugs that might be abused, but their metabolites. So how it breaks down, there are so many ways products that you can buy to flush your system out and whatnot, ways to get around, that if you're not checking for metabolites, you're not, or the signs of those flushing agents, then really your analysis is not valid. And so we want to make sure that we're not just exchanging addictions here. Yes, we do medication-assisted treatment, but it is not just a dose and go program. We want to see treatment of the underlying addiction. So at our clinics, we have treatment of that underlying addiction, and it's mandatory. Now, all opioid treatment programs will offer counseling, but in our clinics it is required, and initially it's required 3 times a week, either group or individual counseling. And so we use a biopsychosocial abstinence-oriented approach, and the ultimate goal is for freedom from all drugs, including methadone. A safe outpatient treatment helps preserve stability. These are people that can continue with their jobs, paying their rent, paying their taxes, and supporting their families and their family structure. Communities that are interested in developing a strategic response, they need to inventory the opioid treatment programs in your area. And here's a website that you can go to find these opioid treatment programs. Like I said, not all opioid treatment programs are the same. So you're going to want to check to see, ask questions of these programs. Do they require mandatory treatment of the underlying addiction, counseling, both group and individual? Do they require daily dosing, at least initially, and then on into the future? You want to also identify wraparound services and anticipate barriers to treatment. Young mothers may need child care. There may be transportation needs. How are they going to get to these outpatient clinics? You want to have all of that put together to develop a pathway for these people to not go off the cliff, but to access the medication-assisted treatment. And then you want to catalog the above services with access and requirements for each program, so that these pathways are very clear to treatment. And then you want to get these pathways to all the first-tier responders. Who are the first-tier responders? Well, that includes doctors, nurses, it includes ministers of churches, it includes perhaps teachers, it includes people in all the social service agencies. A lot of times these are the first people that learn about opioid addiction in the clients that they serve. I want to give you information about how to contact our services. We have Qualpol Counseling Services in Miami, Oklahoma, 918-542-1786. You can go to the website, qualpolcounselingservices.com, or in Oklahoma City, 405-672-3033, or you can go to our website, qcs-okc.com, or the Katua Cherokee Treatment Services in Tulsa, 918-835-3017, and its website is kctxs.com. And all of these clinics serve all people, not just Native Americans, but we serve Native and non-Native people. And all of these programs take Medicaid. So if you're a Medicaid recipient or if you're Medicaid eligible, there is no out-of-pocket expense. Please come see us, give us a call. We'd love to help you get on the path to health.